All right. Welcome, everyone. Thanks for being here for our June webinar, Antidepressants and Lactation. I'm really happy to be here and to introduce our speaker in a moment. This is such an important topic, and I'm really glad that you're here to watch it. And if you're watching the recording, thank you for taking the time out of your day to watch the recording as well. Right. Also, it is June, it is Pride Month, so we want to say happy Pride to everyone and know that you are all welcome and celebrated. Everyone who is here, you're not alone. And I hope that you're taking time to celebrate you and and who you are this month. I also want to let you know that this webinar has been approved by the ANA and, sorry, by the Connecticut Nurses Association and also by the International Board of Lactation Consultant Examiners. And if you would like to receive those contact hours, we ask that you attend this full webinar. I'll be keeping track of attendance and submit an evaluation that I will be sending you at some point in the next few days. There will be a QR code in a moment. So if you want to be prepared to scan that QR code, you can fill out that evaluation right away. I'm at the USBC conference in DC right now, so I might not have a moment to send that right away. And if you are watching the recording, then you can get credit if you have watched the recording, submitted an evaluation, and completed and passed a quiz. And if you are wanting the CEs, I know a number of people have signed up and paid for the webinar, and some people have paid what they can or not paid something. If you would like the continuing education hours in particular, we do ask that you pay that $15 fee. So we can arrange that if you haven't done that. Just let us know. And this is the the certificate of completion that you will receive. And that is the QR code to the evaluation if you want to be prepared to fill that out after the webinar. And the recordings can be found on our YouTube page. So know that that is an option if you have to leave early and you want to finish watching. I also want to say thank you to our annual partners for supporting our work year round and making it possible for us to host these webinars as well. So thank you, especially to WIC, our patron level partner, huge supporters. And we have some awesome webinars coming up as well. We have Ashley Norris, who is here. You can see her video is on. Hi, Ashley, who will be talking about Twice the Love, Twice the Latch, helping families thrive with twins. And I just learned that our speaker has two sets of twins. So maybe Dr. Dragovich will come back for that. And our October webinar, we always like talking about poop in this world, right? So we'll talk about that and nipple pain. So those webinars are coming up. I hope you can join us for those. The registration will be coming for those soon. So I want to welcome our speaker, Dr. Rachel Dragovich. She is an assistant professor of pharmacy practice at Northeast Ohio Medical University and a clinical pharmacist specializing in internal medicine and transitions of care at Summa Health in Akron, Ohio. She earned her Doctor of Pharmacy degree from Duquesne University in Pittsburgh, Pennsylvania, and completed a postgraduate practice residency at Metro Health in Cleveland. She's a board certified pharmacotherapy specialist and a certified lactation counselor. She has completed certification courses in diversity, equity, and inclusion, pediatrics, and pain management. She is an active member of the American College of Clinical Pharmacy, ACCP, Women's Health Practice and Research Network, and the Organization of Teratology Information Specialists, OTIS. Her clinical interests include medication use during pregnancy and lactation, women's health, and internal medicine. So thank you so much, Dr. Dragovich, for being here. Really happy to have you, and I will stop sharing my screen and you can go ahead and start sharing yours.
Thank you very
Again,
much.
if anyone hasn't already introduced themselves in the chat, feel free to do that so we know where everyone's coming from.
Okay, can you see my screen okay?
It is loading. I'm sure it'll take just a moment. There we go. You're good.
Perfect. Thank you, thank you, thank you. Good morning, everyone. So yes, I might need to attend that webinar. We've kind of worked through our journeys, but here's my second set of twins nursing. This was at the 1 year mark. We actually just hit 20 months So, and they're still going strong. So very proud of that. But I won't go into it because we don't have enough time. But the first set is, there were some issues there, and that's what kind of led to my love of teaching others breastfeeding and support. All right, so some objectives today. We'll talk about postpartum depression and the indications for antidepressants. We'll go a little bit into the pharmacokinetic properties and the transfer of medications into milk. And then I'm really trying to be as much of an evidence-based person as I can. So we'll go over the literature that's available regarding antidepressant use in pregnancy and lactation. Some abbreviations, just kind of as an FYI, that I'll use throughout the presentation. Just want to acknowledge that not all individuals who experience pregnancy or lactation identify as women or mothers, but I will frequently use the term women, mother, breastfeeding, chest feeding. Just want to make a statement that these are not meant to be discourage or just include those other people that may identify differently. All right, so a little bit dive into postpartum depression or perinatal mental disorders, mental mood disorders, you might hear them called as. The three really big ones that they talk about are the baby blues. This one is pretty universal. A high majority of people after birth tend to experience what's called the baby blues. And this is just because there's all those hormones, right? You really just went through those 9 months, 9, 10 months carrying one, two, three babies. And you have all these hormones that drop in your experience. So this is just a lability of mood, some tearfulness. It's not uncommon for 3 to 5 days postpartum just to really, not feel yourself, especially if this is your first baby, trying to adjust. Some people might not understand why they feel sad, even though they just have this little bundle of joy. Typically, this goes away after about 2 weeks. Postpartum depression, on the other hand, is any sort of depression that occurs within that first year postpartum, typically lasting 2 weeks, but often longer. This is more extreme feelings of sadness or inadequacy, not feeling like you want to eat, maybe having trouble sleeping or feeling overly tired, which is hard to evaluate with a newborn, but very tearful beyond that baby blues period, feeling anxiety, despair, having some intrusive thoughts. This incidence really ranges. Looking at the literature, there's not great. I think we're getting better at identifying this, but nationally, it's about 14% women experience postpartum depression. The incidence is higher, especially in people that have a history of depression. If you have a history of depression, it's about a 30% incidence of having postpartum depression. So definitely something that's not uncommon. Postpartum psychosis, I just wanted to put in here for inclusive sake. I won't get into like the antipsychotics, but this is something else that can occur. This tends to occur sooner after delivery, but up to 8 weeks postpartum. And this is more like having more of a psychotic break. So not like depression or anxiety, but this is more like hallucinations or manic episodes, those sort of things. This one incidence is much more rare, but can occur, and those instances are often very sad and severe. Okay, so like I said, prevalence really varies for postpartum depression. Risk factors, definitely having that history of depression. If you're potentially doing like a pregnancy or during a pre-delivery consult, it's important to kind of screen for that potentially to have your kind of elevated risk of like, hey, if you have a history of depression, there is that, we want to be prepared for and have much support afterwards. Recent stressful life events. So you just had this baby, what else is going on? Lack of social support. So social support is so important. Family, that village, in-laws, a partner. Unintended pregnancy, so those who were intending to get pregnant tend to have a greater risk of postpartum depression. And then there's also just potential triggers after the birth. So how was that birth experience? Was it premature? Do you have a sick infant? Was there time in the NICU? All these sort of things can definitely, contribute to that stress and lead to an increased risk. Unfortunately, we don't have a great knowledge of the incidence because so much of it goes undiagnosed. Like I said, I think we're getting a lot better, but so many women go for so long undiagnosed. Or you have, a second baby and you realize, oh, hey, maybe I had some postpartum depression with my first, not even realizing it. Or you have a friend that also had those, whoa, those feelings weren't normal. Or like you kind of compare and contrast and you realize, oh, maybe I did have a little bit of that. There is a screening tool. They call the Edinburgh Postnatal Depression Scale. Some of you guys may have used this in practice before. They tend to give this a lot at the pediatrician voice in appointments that the newborns are following up with, and sometimes at OB appointments as well. This is really just a 10 question based little questionnaire that takes, less than 5 minutes. They basically ask, how have you felt in the past 7 days? Have you been able to see the joy in things, the funny side of things? Have you been able to sleep, which I always thought was really funny with the newborn. But if you score greater than 10, or if you report having thoughts of suicidal ideations, then that's considered positive, and potentially need to look further into risk of postpartum depression. Unfortunately, why is this a problem? So obviously, this is a big concern for maternal mental health, right? Women with postpartum depression may experience suicidal ideation. They may be in harm to their children. Unfortunately, maternal death from suicide compromises about 20% of all postpartum deaths. So number is way too high. When it comes to breastfeeding, I would say the results are a little bit mixed. We don't have a whole lot of studies. There was one recently that just came out, but kind of depending on where it goes. So if breastfeeding is going really well, it can potentially enhance that bonding experience and improve the mood with the baby. However, if mom's having latch problems, if she's having pain, if she has having perceived low milk supply, if baby is in the NICU or she's doing a lot of pumping or things just aren't going the way she thought they were, then this could potentially lead to increased risk of depression and anxiety. I think too, nowadays, we have all these apps and social media and people are just comparing themselves to others, which most times I don't think is helpful and can just kind of make people's anxieties and their expectations of what they think is going on. Even if things are really going great, they might not feel that way. Maternal depression and lack of support, social support, and clinical support are causes of early weaning. And then untreated postpartum depression can not just have effects on the mother, but again, also the infant, the family members, everyone around kind of can be affected by that. So it's really important to treat mental health as protective for the baby and the mother and everybody in that household. So again, I'm an evidence-based person. I'm a guideline-based person. So where do we look at for, guidance on these things? A couple different ones. The Academy of Breastfeeding Medicine is a great resource. Their Protocol 18, unfortunately, hasn't been updated in over 11 years. That was the use of antidepressants in breastfeeding. I mean, not a whole lot has changed there. So that's still a good resource, but that was one to look at. A little bit more up to date is ACOGs, or American College of Obstetricians and Gynecologists. They have a clinical practice guideline number 5 that talks about treating mental health in pregnancy and postpartum. And then they recently just put out an update on some of those Zuranolone and Breastfeeding products that we'll talk about as well. So, what does treatment look like for postpartum depression? Treatment generally includes psychotherapy plus or minus pharmacotherapy. So, really, this should be a decision, after it's identified on the Edinburgh scale, or if somebody, brings it to the light of a physician and it's diagnosed that yes, you have postpartum depression. What are we going to do to treat this? So, psychotherapy is great, and some people don't want to go the medical route. If it is extremely severe, though, sometimes you need to start pharmacotherapy before you can feel ready to start that psychotherapy. So, in an ideal world, we would have both. We would have mom seeing a counselor, weekly or more if needed, and then also getting started on some pharmacotherapy in those severe cases. But this should be a shared decision making. So, if mom does have a history of treatment, or postpartum depression, what treatment worked previously, especially when it comes to medications. Things that worked well in the past will tend to be something that we'll go to again. Or if, mom or sister had depression at one point, what worked well for them. We'll talk a little bit about the SSRIs, which is our first line therapy. There's a lot of different agents. When it comes to those, people just kind of respond differently. You kind of pick one based off of side effects and kind of what we're looking to get out of it, as far as some of those side effects, sleepiness versus more wakefulness, things like that. If a mom was already well controlled on an SSRI or some sort of other agent in pregnancy, we generally continue that postpartum, and we'll talk a little bit more about that. So what antidepressants do we have? There's a lot of different agents on the market. Our first line, like I said, are SSRIs, or those are selective serotonin reuptake inhibitors. Those are usually our first line gold standard agents. So those are things like citalopram, escitalopram, fluoxetine. Fluvoxamine isn't quite as big. Paroxetine you won't see as much in the younger population because that one's typically not recommended for women of childbearing age. And then sertraline or Zoloft is a very popular agent. Our other agents specifically for postpartum depression are newer agents, are neuroactive steroids. We'll talk a little bit about those, Zuranolone and Brexanolone. And then our SNRIs, which is our serotonin norepinephrine reuptake inhibitors. Those are duloxetine, venlafaxine, and desvenlafaxine. We'll touch upon those briefly because they're very similar to the SSRIs. I included tricyclics and atypical agents here for completeness sake, but I'm not going to go in those because those are typically third, fourth line adjunct therapies and kind of a little bit more nuanced. You will sometimes see people on these for other indications. So like SSRIs potentially for like anxiety, OCD, they're used for PTSD, things like that. SNRIs can sometimes be also used for like neuropathic pain. The neuroactive steroids are specific to postpartum depression. All right, so let's dive a little bit deeper into the fun stuff, the pharmacy stuff. So again, looking at our guidelines, what do they have to offer us? What do they say? So the Academy of Breastfeeding Medicine states that treatment is strongly preferred, and they say that sertraline is the most likely SSRI to be prescribed, and we'll kind of talk about why that is. ACOG has a similar statement. They recommend that SSRIs be used as first line, which is our general guidelines for the general population as well, if we need to use pharmacotherapy. And then they say to individualize that based on their prior response. If they had no prior therapy, then they recommend either sertraline or escitalopram. And again, we'll talk about why that is. And then when it comes to our newer agents, they recommend using Zuranolone for severe depression that has onset either within the third trimester or within 4 weeks postpartum. Okay, so a little bit about medication transfer. I can go on, there could be a whole other talk on this, but one thing that I want to reiterate, and probably not so much to you guys, but when I present to like physicians and prescribers, is that pregnancy and lactation, taking medications is much different. So there's several medications that are contraindicated in pregnancy or may have perceived negative outcomes or actual like negative outcomes in pregnancy that are perfectly fine to use in breast milk or breastfeeding. Really, when the baby is in the mom and in the placenta, everything in her bloodstream is going, getting mostly to that baby. When it comes to the breast, things are different, right? So really kind of thinking about how it gets in there. So the biggest thing first is that it has to get absorbed in the mother. So she has to take that medication and it has to be absorbed, metabolized, processed, and get into her blood. So there's some medications that aren't even absorbed. After it's absorbed, it needs to get into her circulation. So the biggest thing that's going to tell us about transfer is, what is the amount in mom's serum? What's the amount in mom's blood? And then from the blood, it has to get into mom's milk. So from that bloodstream, how much of it over it is transferring into mom's milk? And then that's still not even the final step. From mom's milk, the infant needs to ingest it and it needs to get into the GI tract and then into that infant circulation. So just really thinking about, this is more of a broad, not just in relation to antidepressants, but really when mom's taking a med and whenever we're evaluating, like, is this medication safe in lactation? The majority of meds are going to get into the breast milk in some degree, but very few of them have really like a clinically meaningful impact on the infant from mom's milk. Again, just kind of as an overview, what properties increase the likelihood of transfer? So if they have a high plasma concentration in mom, a low volume of distribution, a longer half-life, a low molecular weight, so typically less than 500 Daltons, low protein binding, so not highly protein bound, and if they pass into the brain easily. So things that tend to be psychoactive drugs tend to, because they can cross that blood-brain barrier. The blood-brain barrier is a lipid barrier. It's very similar to the barrier between mom's blood and mom's milk. So again, like antidepressants, things like that, they do tend to get into the milk, and that's why, because they pass into the brain pretty easily. So our preferred drop properties, if we're specifically looking to reduce exposure to the infant via breast milk, would be looking for things with a short half-life. However, once you're at steady state, that doesn't really matter anymore. A high molecular weight, so more than 500 Daltons. Unfortunately, most of our oral medications aren't more than 500 Daltons. High protein binding, so if they're bound to proteins in the blood, then they're not getting through that barrier. Poor oral bioavailability. So again, this doesn't apply to antidepressants, but things that just work locally in the GI tract wouldn't produce high concentrations in the blood or the milk. And then low lipid solubility, so more water soluble. Again, just general resources. Hopefully, a lot of you are familiar with this, but these are always my go-to when somebody wants to know if something's safe to use or what data we have for information in pregnancy and lactation. The Otis has this source mother to baby. They have a website which have these really great fact sheets for patients that they can go on and look up medications and even just other exposures like sunscreen and all these other kind of things that really give good patient understanding language. LactMed is my absolute favorite database in the world. You can actually go in there, and this is run by the NIH, and look at for a medication, and it gives you all the information that we have evidence-based for. Does it transfer into milk? Is there an effect on milk supply? Is there an effect to baby? What information do we have? And that's pretty constantly updated. Elactensia is similar. You can also type in meds, and they'll give you that. Some textbook Hales, I think, is kind of like the Bible for a lot of lactation consultants. We'll talk a little bit about that. Briggs is another one, and then the Infant Risk Center, which is run by Dr. Hale and Caitlin over at Texas Tech. They have an app, I think, now, and you can call too as well. So this, again, I don't want to spend too much time on because we don't have a lot of time, but this is if you do use Hales, they kind of break it into these lactation risk categories. And I go over this because I do include this with the drugs. He ranges them as L1 is compatible, which has been taken by a large number of breastfeeding mothers. We haven't seen any issues. So this is like your Tylenol, right? Or things aren't even that bioavailable. L1, completely compatible, as opposed to L5, which is hazardous. So this would be things like chemotherapy, where the risk is just too great. And then there's this weird category of L3 that I don't love. So this is one where it's like, we really don't know. There are no controlled studies. And we're really not sure. I would also like to put the caveat in here that he states that any drug that comes to market that is new and we don't know is automatically put into the L3 category. So I would just say in practice, if you see something that's an L3, maybe do a little bit more digging and research yourself and don't just rely on that category to be too simplified. All right, so talking a little bit more about SSRIs. So their indication is usually for depression, but also some other mood disorders. How they work basically is you have serotonin, dopamine, norepinephrine, GABA, you have all glutamate, all these different neurotransmitters in your brain, right? And they all do different things. Well, serotonin is really kind of like your happy hormone, right? So what it does is, your brain will produce serotonin, and then it kind of has these I don't know, you can consider them like little trash cans that they eventually go into. They're released and they eventually go into these little trash cans in your brain. But basically, what these drugs do is they kind of put a lid on those trash cans so that they can't be trashed and they just hang out in your brain longer. So this can improve mood and anxiety. So those happy hormones, they don't go away, they kind of just hang out longer in the brain. I already talked about the agents. As far as some side effects, so potentially GI upset, some patients report diarrhea, constipation, headaches, sexual dysfunction, sedation, insomnia, agitation. Again, this is just kind of universal side effects for a lot of them, and sometimes it's a little bit of just trial and error of somebody will do better on citalopram versus somebody else does better on fluoxetine. We'll just kind of start one and kind of see. Always want to go on the lower end if we can and kind of titrate up to our best effect. Serotonin norepinephrine reuptake inhibitors, only big difference here is that they also stop that kind of degradation of norepinephrine. So they increase serotonin as well as norepinephrine and a little bit of dopamine. This can be helpful potentially to be more of like an activating agent. So especially if people are having if they're very tired throughout the day, and that's one of their main symptoms, this could be helpful to take in the morning. And then sometimes these will also be used for patients with neuropathic pain because they can help that as well. They have a lot of this similar side effects as the SSRIs, and it's a very similar, like you kind of just start with one and see how that goes. As with any medication, you want to start at the lowest dose tolerable and then kind of increase up until we see an effect, and then you don't have to go to the max dose. So my first question when I was kind of diving into this lecture is, how helpful are medications for postpartum depression? What data do we have to say that we should use these medications, and are they helpful? And there's actually pretty good data that they are very helpful. So there was a meta-analysis that specifically looked at 4 random controlled trials in patients with depression, and looked at those who were taking SSRIs versus taking placebo or treatment as usual, which might just be psychotherapy or what have you. And they specifically used that Edinburgh Postpartum Depression Scale or a HAM-D scale, which is just your usual depression scale. And really, they saw a good response. They saw that more than 50% of people had a reduction in that, or had a reduction in that scale. So about 55% had a response of more than 50% reduction in that scale. So say they scored a 20 after treatment, they checked it again and they scored like a 10. So a lot of them, they did seem to work pretty well. And then there was a second trial that I just pulled here that was specifically just looking at that EPDS score in postnatal depression. And they specifically looked at 4 weeks, and they saw that almost 50% again of patients that received an antidepressant versus those who just received psychosocial support did have a significant decrease in their depressive symptoms. So, are they helpful? It would seem so. So then my second question was, how does the use of these medications in pregnancy and in lactation, how does that affect our breastfeeding outcomes? How does that affect the mom and the infant? So there are some studies that suggest that antidepressant use during pregnancy could potentially lead to poor breastfeeding outcomes, such as difficulty establishing supply, decreased initiation of breastfeeding, or reduced duration of breastfeeding. So these are a few studies that I pulled out here. The first one here was just a small prospective study. Really, I mean, the N was 8 in the mothers taking SSRIs compared to the controls. But this was a study that I think some people do talk about a little bit. So this basically was moms that were taking SSRIs during pregnancy. And what they found that those who were taking it did have a delayed lactogenesis too by about 16 hours. So a little bit delayed milk coming in. However, there was no statistically significant difference in whether or not they had feeding difficulties after 4 days postpartum. So this study, so potentially some concern for a little bit delayed, milk coming in. But as we know, that could potentially happen with like C-sections and stuff like that too. The second study looked at those exposed during pregnancy again, and they basically compared those who were exposed at time of delivery versus those who discontinued prior to delivery versus those who were not exposed whatsoever. And they found that those who were exposed prior to delivery and at the time of delivery were significantly less likely to initiate breastfeeding as composed to women who did not take SSRIs at all. So kind of hard to say why, but those for some reason who were taking SSRIs didn't initiate breastfeeding as much as the ones who did not take SSRIs. And then the third was just an observational study. This one, again, looked at women who were taking antidepressants within the last 2 years, so a little bit longer, and continue them during pregnancy, versus those who were not taking them. And they found that women who were exposed to antidepressants were 30% less likely to be breastfeeding at the time of discharge. So what I gather from these is that these women need more support from us, right? From more support from lactation consultants, more support from anyone working in that postpartum period. And from these, it's kind of hard to say, was it the medication or was it because of, the reason they were taking these? Is it because they had some history of depression, something like that? So and to try to tease that out a little bit, is it the drug or is it the mood disorder? So looking at this first study here, this was compared women who were taking antidepressant during pregnancy versus those who had a psychiatric illness but were not treated versus mothers with no psychiatric diagnosis and not taking meds. And what they found in this one was that exposed women were 37% less likely to be breastfeeding upon discharge, but there was no difference when they compared this to women that also had a psychiatric illness but were not treated. So to me, this kind of leans towards it's more due to potentially the psychiatric illness than it is the drug. But again, just needing increased support. And then the second study, again, just kind of looking at unexposed mental disorder group versus was specifically looking at if they use them in late gestation or earlier mid gestation. And then again, it was just kind of, to me, it's telling me that these people just need more support, that we really need to support them as much as we can, especially if we have history and knowledge that they have a history of depression or any sort of mood disorder. Other thing to be mindful of, so if mom was taking these during pregnancy, is that exposure in utero may lead to something called PNAS or poor neonatal adaptation syndrome. This is similar to if you think about like neonatal opioid withdrawal syndrome or NOWS. This is much more milder form of that. But again, basically this baby has been exposed to this for, 9, 10 months in the system. And then we're taking them out of the womb and they're shocked and they're not longer be exposed into those high levels of serotonin or norepinephrine. The incidence of this really ranges very widely among studies. It's kind of hard. They don't study it too well. Like I think I saw 5% up to like 20% in babies that were exposed. But typically, if it's going to happen, it happens within 72 hours of birth and typically resolves within 2 to 4 weeks. This is very similar to why we tell patients, not to stop a medication abruptly, especially things that are neuroactive. Like I would tell any of my adult patients, these are going to be very similar. If you've ever taken SSRI and SNRI and maybe you ran out a couple days earlier, you went on vacation, you forgot to take it, usually you'll have like a headache, maybe some blurred vision, you'll be agitated, could have some GI upset. So similar in infants as well. When it comes to which agents are more likely to cause this, so there was one study that looked at specifically duloxetine and escitalopram, and they said that those might be the ones that had the highest rates of PNAS, whereas sertraline maybe have the lowest. And this again could be due to like half-life, exposure, and crossing over the placenta. Um, all this being said, it's not recommended to stop antidepressants or lower the dose prior to delivery. Typically, we can treat PNAS if it does occur. I will tell you that I was on SSRIs with my first, and it didn't seem like they had this, but it does happen. But really, typically, protecting mom's mental health is going to be more important. And this is typically just managed with supportive care. So offering reassurance, frequent feeding, skin to skin. There are some evidence that PNAS might be lower in breastfed babies compared to infants that are exclusively formula fed. I don't think that this necessarily has to do with like transfer, but probably more so just because, close proximity to mom, more that skin to skin, more that contact. But breastfeeding can potentially help reduce in that if somebody is concerned about that. Okay, so this just to orient you guys to this table here, and I just kind of included it for, if you need a reference in the future. But the SSRIs, the brand and generic name is all the way at the left side. Your typical adult daily dose that you'll see, the half-life, so this is how long it takes for half of the drug to be eliminated within mom. The RID or the relative infant dose, which is something you guys might be familiar with. So this is how we kind of pharmacologically estimate how much we think the infant is being exposed to via breast milk. For the most part, we think that things less than 10% are considered compatible or acceptable. Some different studies now are saying for things psychoactive, more like less than 7%. But that's kind of what we have there. Protein binding, oral bioavailability, and their molecular weight, and then Hale's classification. And then again, just the same drugs here and pointing out some side effects. So the potential side effects in mom, these are reported in, package inserts and studies, but these are typically pretty universal. And then I went ahead and tried to look at specific studies for each medication and specifically, so we talked a little bit about their use in pregnancy and how that affects mom and baby and their use immediately postpartum. And then this is specifically looking at moms who took these medications during lactation and were there any impact on the infant or did they have any side effects? So again, sometimes this stuff is a little bit hard to tease out because mom might have also been on it during pregnancy. It's hard to know from case reports if it's specifically due to the drug. But potentially with that citalopram rather, there are some reports of colic, decreased feeding, irritability, and restlessness. In some cases, there have been reports where that RID has exceeded 10%. So this is usually why we'll typically lean towards escitalopram instead. So these haven't had no big side effects. There's one case report of an infant that developed neck, but this was after being exposed in pregnancy and via breast milk. And again, it's hard to know, what exactly that was due to. The drug was just kind of one factor there. Fluoxetine is one people tend to shy away from because it tends to have a higher RID and a really long half-life, but it works really well in some patients, so we still might see them on there on that agent. But there have been some case reports of colic, fussiness, decreased growth, so something to watch out for. Fluvoxamine and paroxetine actually have no side effects that have been reported, but they're also not used very commonly in this population. And then sertraline is that one that our guidelines tend to recommend the most. This is probably because the drug levels are really low, and it's commonly used, is considered safe in pregnancy as well. And our drug properties tend to be pretty good as to not transfer. There's a few case reports of agitation, and some things to watch out for with the baby, but overall, for the most part, generally well tolerated. And then again, here's just kind of that same table with our SNRIs. These ones, so all the other ones I think were L2s. Hales does put duloxetine and does venlafaxine in that L3 category. So again, do a little bit more research. Again, just kind of pointing out some of those side effects and some comments for those. So what are our key points here? So ACOG and ABM both recommend SSRIs as first-line pharmacotherapy for perinatal depression, preferably with psychotherapy if that's possible as well. Sertraline may be preferred or Zoloft in patients that have not taken anything previously, and that's just due again to kind of like those lower levels in milk, as well as in utero. Infants exposed, we have to be on the lookout for some of those PNAS symptoms that might affect feeding and just, even mom's mental health. It's not recommended to stop or lower the dose prior to delivery. That tends to be more risky rather than just continuing. Mothers taking antidepressants may be more likely to have breastfeeding difficulties and would greatly benefit from additional lactation support. So I don't know if you're in a hospital somewhere and maybe you can't see all the moms, maybe you could do something to flag, somebody on an antidepressant, does somebody have a history of depression? Those are the patients that I want to see first. And then, mothers taking antidepressants or any drugs during lactation should monitor infants. And then all SSRIs tend to transfer to some degree, but most have a RID less than 10%. Some concerns with like fluoxetine, citalopram, but most of them have a RID less than 10%. Sertraline will be the one you probably see the most often. Okay. That was our SSRIs. Now moving over to neuroactive steroids, which really is the only FDA approved treatment specifically for postpartum depression. So these came out a few years ago, and basically how they work is on the GABA receptors in the brain. And those are usually like our more sedating receptors. The first one that was approved back in 2019 in the US was called Brexanolone, and this was actually a 60-minute IV infusion. So patients actually had to go in, be monitored, receive this infusion, but it was just a one-time infusion. This is no longer available in the United States as of January of last year, and this is really just because we have a new agent called Zuranolone, which is oral. So, why would you go in for a 60-minute infusion when there's an oral drug available? So we're specifically just going to talk about that newer agent, that Zuranolone. So again, is it effective? There was a couple studies that they looked at, so looking at specifically at Zuranolone and postpartum depression, and they, randomized women to receive either Zuranolone or placebo, and for 14 days, which is how long this medication is used for. And they, for some reason, looked at the HAM-D in this score, which in this study, which is weird. They probably should have looked at the EPDS, but research isn't perfect. But basically, they did find a statistically significant difference. In both studies, really, the decrease in symptoms were over 50% in the treatment groups for both of these. So it is showing that it is effective. In some of these studies, women were also taking SSRIs as well. So talking a little bit more about Zuranolone or Zuzavwe, the usual dose that we'll see is 50 milligrams, excuse me, by mouth once a day in the evening for 14 days. So it's just a 2-week treatment. It is recommended to take with a high-fat meal as that helps increase absorption. The biggest thing we worry about here is that CNS depression. So it's working on those GABA receptors, which are really like your sleepy receptors. Those are things that also alcohol works on. And so worrying about dizziness, CNS depression, and then as with, any psychoactive agent, potentially suicidal thoughts and behaviors. It is a controlled substance just because of that effect on GABA. So because of that, it's also only available at specialty pharmacies, so this makes it a little bit more difficult for patients to get because of those two things. There are some drug interactions to worry about, so if mom's on a lot of different medications, obviously speaking to a pharmacist might be helpful. It's also very expensive, so our SSRIs, you could probably get a full 30, 90-day SSRI prescription for under $10. This agent here, the average cost of treatment, wholesale price is about $19,000. Hopefully, that's not coming out of mom's pocket. There's insurance and other things, but significantly much more expensive than our SSRIs and SNRIs. There are some patient assistance programs for commercially insured patients, but kind of a lot of hoops to jump through to get this medication. So, looking at what ACOG had to say in their 2026 update, these were their considerations. So they specifically had said, patients who have, they recommend patients who have severe postpartum depression. So that would be that Edinburgh scale greater than 19, especially within 4 weeks postpartum, they would recommend using Zuranolone. Few things that they point out for at least 12 hours after, patients should avoid driving, operating heavy machinery, which is funny, but engaging in dangerous activities and caring for their infant alone. So this is really huge, especially if you work with patients that might be prescribed this. After they take that dose, they're going to be very, very sleepy and potentially groggy and not remember things. So there needs to be a feeding plan in place. There needs to be somebody there that is going to be looking after mom and baby. I heard one story from a client who was taking this, and her husband was going to be the one that was helping her overnights. Um, and she had woken up and her infant was in her lap, and she didn't remember that infant being there, and her husband was fast asleep. So he probably intended to help, but I don't know if he's anything like my husband, who a baby could be screaming in his ear and he's no help whatsoever. So making sure they have somebody, a postpartum doula, an in-law, somebody that can actually stay up and they have a plan, place and feed, place a plan for feeds in place. So mom could get up and pump and, even potentially feed the baby. But there needs to be somebody there helping to do that. I also think this is interesting. So the ACOG says in here, patient's clinical need for zuranolone and the developmental and health and benefits of human milk feeding should be balanced through a shared decision-making process. Pumping and discarding human milk through 1 week past treatment, given the absence of direct infant data, is a consideration and should be contrasted with possible continuation. We'll talk a little bit more about this. I don't love this statement. Okay, so what information do we have on zuranolone? We found that it's probably helpful for postpartum depression. How does it affect breastfeeding? So this was a smaller study, it was just a phase 1 study, but they looked at a 30 milligram dose once daily for 5 days, and they looked at concentrations in milk and plasma on day 5, so after it got to steady state. And basically, they found that the mean daily infant dose at day 5 was estimated to be 0.00125 mg per kg per day. This is a RID of about 0.35%. Very, very low. So very, very low. So I don't, I think ACOG's statement probably comes from an abundance of caution. But from these studies that we have, it's very low exposure via breast milk. This was done in the 30 milligram dose because that's what they were originally testing. The dose on the market now is a 50 milligram dose. So what they ended up doing is another calculation to estimate that RID. So the estimated RID with the 50 milligram dose is still less than 1. So approximately 0.74 to 0.9% in an infant taking 150 to 200 milligrams per kilogram per day. So, in my opinion, very low transfer. Again, always a risk and things to watch out for, but very low transfer. So, I think the biggest thing is just making sure that somebody is there to help mom feed, whether that's pump or directly feed. One thing that was interesting in this study, they did notice that there was a slight decrease in breast milk volume at day 5, so an 8.3% decrease. However, this wasn't their primary outcome, so this was just a secondary outcome that they happened to notice. So it's hard to know if it's statistically significant. So potential risk for decrease in milk volume, just maybe something to watch out for and counsel on. So looking a little bit more at this, it is a really long half-life. Again, it's only a 2-week course, which is great for mom, but it does stay in her system for a pretty long time. It's very highly protein bound, a low RID. Again, very unlikely to, one, we show that it didn't transfer much, and then again, it has to get through all to baby, most likely very low exposure to baby via breast milk, but watching out for mostly just sedation. It is expensive. It's kind of hard to get, but it does have rapid onset, which is really nice. So again, more than 50% of patients reported, pretty significant improvement in symptoms. So what about maintenance and monitoring? So if this is a patient's first ever depressive episode, or if they've only ever had perinatal depression, monitoring should begin 1 week after recovery, then every 2 weeks, then a month. So a lot of monitoring after they receive this agent until they get to 1 year of remission. If at any time the patient begins to decompensate or has, more feelings of depression after that 2 week period, once they're off, we would not give another dose. So you don't do another treatment course of Zuranolone. At that time, they recommend going on an SSRI or a standard antidepressant therapy. And then another caveat, if the patient has a history of depression outside of the perinatal period, so say, in their 20s or, even if it was several years ago, they were on an antidepressant, it's recommended to start at maintenance treatment at the time that they get that Zuranolone as well. So it's not uncommon to see both. So say a patient wasn't on anything during pregnancy, but she has a history of depression, she gets postpartum depression, it's severe. We're going to do Zuranolone and probably a sertraline or something that worked well in the past for her. So you might see patients on both. Key points that Brexanolone is no longer available in the US. So that Zuranolone is the one you're going to see. It's really no longer available anywhere because the manufacturer is not making it. In patients who have severe depression, especially within that 4 weeks, but really anywhere up to 12 months, we can consider that Zuranolone. But again, that should be in the context of shared decision making, weighing things like cost, how soon are we going to get treatment. Um, there's no studies, unfortunately, right now that are like directly comparing patients just on SSRIs versus patients just on Zuranolone, which would be really nice to see. Um, but this is an option, especially if we're really concerned. We want a really fast onset. With SSRIs and SNRIs, it takes up to 4 to 6 weeks to see a full benefit. Sometimes you could start to see an improvement within 2 weeks, but really to see that full benefit, it's 4 to 6 weeks. And again, you might have to up titrate that dose. So that's something to worry about too, especially in this time period. I mean, 6 weeks, a baby from a newborn to 6 weeks old is so different, right? They're starting to track, they're sleeping a little bit longer stretches, like they're doing all these different things. They can see you better. Like there's such a big difference within that time period that in our general population, when I tell them it's going to be 4 to 6 weeks, maybe it's not such a big deal, but maybe with mom it is. Maybe we really need that rapid improvement within 2 weeks. And then breastfeeding patients, I would say with either encourage breastfeeding, just be aware of that significant CNS depression that can occur and really have a good system for night feeds, at least within the first couple doses, but potentially up to that whole 2 week period. So, after mom takes that dose, let's have a night doula, let's have mother-in-law, let's have, somebody there that can be helpful and have a plan in place. And then, of note, just if somebody does take Zuranolone, they might still need treatment with the SSRI. So it's not, it's something that they still might need both. So if we're just trying to avoid an SSRI, not necessarily, might not work just using Zuranolone. These are my references. I think I met our time goal. I'm going to stop sharing and then I'm happy to try to answer any questions you guys may have.
Awesome. I don't think I saw any questions go in the chat yet, but there's time if anyone has any questions for Dr. Dragovich. I was wondering if, like, do you feel like most pharmacists and obstetricians are aware of everything you just shared, or is there still education needed?
No, not at all. And no, like when it comes to anything breastfeeding related, I mean, I think so often they think it's just very simple to either like what I said, like they think if it was contraindicated in pregnancy, they're thinking everything getting to the baby, and they're really in their mind is just they don't think about the importance of the breastfeeding relationship, I think. And so that's when you get a lot of this, oh, just pump and dump, just give a bottle. Um, but they don't think about what that also has to do with mom's mental health and those sort of things. So no, I think educating and that's one of my biggest goals and what I want to do is I love talking to prescribers and giving them this information and those resources because they don't understand the importance of no, I don't we don't get a lot of education. I think I had maybe a half-hour lecture on lactation when I was in pharmacy school. And no, it's very,
And not to say they don't want that information, they just might not know it's there.
yeah.
So I think for everyone watching this, this recording is something that you can be sending to people, and you're okay as well, Rachel, with sharing the PDF that you sent me that I'll be sending
Mhm.
everyone, if that's something that people could be giving to the OBs in their world or the pharmacists in their world. You're okay with that?
Yeah.
Awesome. And I also have another question you mentioned the frequent follow-up that's needed for folks when they are on that medication. Who's responsible for that follow-up?
That's another great. Who takes responsibility for mom after the baby is born is in my world. It seems like everyone's so hands off. The OB is like, no, that's the PCP. The PCP is like, oh no, that's the OB. I don't know.
Mhm.
I would hope that, yeah, I can go on a
Yeah.
whole other rant about women's health and care postpartum and what we're doing and why isn't there more follow-up and it does think and like the thing I think is weird too is the pediatrician's often the one giving that EPDS, but they're not going to treat mom. So if they realize that she has a higher score, then it's referral and there's still ownership probably on that mom to follow up and it's just such a lack. And if anyone has a good system that they've seen in place, I would love to know more about it because I think
Yeah.
it's lacking. I do. And I would hope it would be the PCP. I think that would probably be if you have a great primary care provider. But I don't think, no one person is really owning this. I don't think if you aren't already established with, a counselor and sometimes people that even have psychotherapy often aren't the ones that are also prescribing. Often it's just a counselor, somebody it's not necessarily a psychiatrist.
Mhm. Yeah, and I would think that whoever's prescribing the medication would be the one that would be taking ownership for that. But I know that those follow-up phone calls aren't happening in a lot of places. And again, as much as they would like to be able to do that, I think that capacity is limited. And I know that we have quite a variety of professionals who are on this call now. And we can also be a part of that by doing those follow-ups and check-ins if you know that they're on this medication, or any medication. I know we're all wanting to just check in on them. So thank you for letting us know the importance of that frequent follow-up and monitoring. And I see Mary's comment. I'm so grateful that we are shining the light and talking about mental health for our mothers and that there's help out there. Also, a big plug for PSI, such a great resource. And Ashley agreed. I went to the PSI training that was in Maine a couple of weeks ago and found that really helpful and shared what I was learning about there is a pharmacology section, and I was sending that to Rachel to show her what they're saying in PSI and to encourage her to get involved with them too, because it sounds they were saying that they would love to have more pharmacists a part of the PSI world. So I hope that that can happen.
Me
And
too.
yeah, Mary Lee, thank you for the reminder that public health nursing and home visiting resources are great supports for moms too. And
Should be
yeah,
standard of care. That would be lovely.
exactly. All right, I see a hand up for Ismatu. Am I saying your name
Hi,
right?
yes, my name is Ismatil. I'm
Ism.
from Tucson, Arizona. I had a question in regards to kind of, or a comment to make in regards to SSRIs and breastfeeding. I found a lot of like disbelief in the mother if they're reporting like a decrease in their breast milk supply when it comes to speaking to the provider. And the provider really refers to like, well, the book says that you're not supposed to have a lot of interaction, so I don't know what's wrong with your situation, but the book is saying, you know, your interaction is not supposed to be a lot. And the mother's saying, well, I noticed a decrease in my milk supply. And the provider saying, well, you're not
Mm.
supposed to. So, do you have any feedback as to how to navigate that in particular from others who need the antidepressants and need that extra support, but are finding it difficult to communicate or to get through to their providers as to what they're experiencing?
Yeah, I would say so. Tell me if I'm hearing this correctly. Like a mom said that she had a decrease in supply, but the physician or provider is saying, well, my literature doesn't support that that should be happening. So I don't know why. Yeah, I would say I think that's such a hard thing to know too, because when it comes to that decrease in supply, as we know, like it could be so many things. Did she just hit regulation? Is it because she's pumping when normally baby's latching and the flange and the pump and stuff? But if it is a true decrease in supply, it could also be, is she fixating on that? Um, when it comes to the provider, I think you could just, the biggest thing for them would be educating on, hey, we don't have a lot of information, unfortunately, for literature and breastfeeding, and everyone responds differently. To take her, I always want to take those concerns seriously. There could be, obviously some things to teach out there, but when it comes to the provider, I would probably just let them know, like, even those studies I showed you, it's like an N of 8. I mean, that's nothing compared to our giant studies. Like, we don't have our robust literature. Like, this is just what they found in kind of a handful of people. Um, that's Sorry, that's probably not a great answer, but I think maybe just educating them that we don't have as much data as we wish we did. And then, with mom, taking her concerns seriously, but again, probably trying to tease out, what's really going on. It could be the medication, but then it could also be lots of other things too. I think that's
Yeah, I
fine.
feel like I've heard that with birth control too, where some moms are saying, really nothing else changed, but I started taking this medication. And doctors sometimes responding with, well, it shouldn't be impacting your milk supply. And so I think like we don't just want the conversation to end there and have the mom feel like, okay, no one's believing me or no one's supporting me. I think we want to connect them to those other resources. So like lactation support, who can really do a full, thorough um, uh, check on anything else that could be impacting that supply and continuing that conversation with the whole care team as much as possible.
I mean, there's things in medicine all the time where we start something and then something happens, like the patient, gets a fever or has a liver injury, and we're like, what happened? This medication's not supposed to cause that. I'm like, yes, but we ruled out everything else, and maybe we're just the first ones discovering that, yes, this medication is what caused that in this patient because every patient's different. So, like, it's not unheard of, yeah. And that, we don't have reports of it. So, yeah, they should be familiar, but I think they want to say, no, it's not. But we don't have
Hmm.
all the data. This is why we need more research.
I know. And so I'll say I was on Capitol Hill yesterday visiting with Maine's US reps and senators. And one thing I was advocating for is more research and continuing funding for data collection, but also more research. There's just not enough research in lactation and women or women's health in general. But this is definitely an area where we need more research. Any other questions or thoughts? There's so much good information, and there is some research that's been done, right? And so it's so helpful to have you pull it all together for us to be able to then interpret and carry on in our work. So thank you so much for doing that, for sharing this with us today.
Of course.
And thank you everyone for being here and for sharing this recorded webinar too with anyone you think might benefit from it. And I'll be getting that PDF of the handout out to you in the next few days. And I thank you all so much.
Thank you, everyone. It's been a pleasure. Feel free to reach out. Anything, happy to chat, email, anything, LinkedIn. Thank you.
So thank you so much. Have a great day, everyone.